I'm consulting gastroenterologist in Muscat, Oman, and it's my pleasure to welcome my co-faculty member and friend, Dr. Morteza Shafazand, on the second episode of this polypectomy webinar series, where we're trying to go through A to Z polypectomy in everyday practice, but also try to speak about slightly more complex procedures as we go on. So, Morteza, thank you so much for joining us again.
Thank you very much, Summer. It's always my pleasure to be with you and your friends, and thank you again for having me.
And we spoke about diagnosis, how to think when you're doing like a colonoscopy, the optimal technique, how to find the polyps, how to standardize your terminology, whether we're dealing with an adenoma or a ulcerated lesion, or when to resect and discard, when to save them and send them for pathology, and so on. But in today's episode, we're gonna go to the next step, where we're gonna be speaking about the process of polypectomy itself. So we've made the optical diagnosis, and now we have decided that this polyp is to be removed. So my first question to you would be, what is your practical framework for deciding between like cold snare, hot snare, EMR, or don't touch this, just like take pictures and send it away? How do you think about those things? How do you square them out in your head?
Of course, when I have made the assessment regarding to what I think the lesion is about, and what is my competence to treat that, then I decide to do or not to do it. And that if it's and also if I see that this is a lesion that is resectable, and I can do it, my team is with me, etc. So then I decide what kind of resection is it suitable for this lesion, and for that there is a very good description in the ESG guidelines that you can see what kind of lesion is suited to what kind of endoscopy resection. But I have to say that most of the lesion, as you know, is a small diminutive or small lesions, and the most procedure I do on daily basis, if I look at the regular colonoscopy, is of course cold snare polypectomy, because up to 1 centimeter you can easily take it with the cold snare polypectomy, and also if as it's in the ESG guidelines, it's all sessile serrated lesion without dysplasia, no matter of size. You can use cold snare polypectomy then in many pieces. I'm going to touch it as well in my slides. So then I go for the procedure just based on what polyp it is, and also not only that one. If you are very good at EST, but you see that this access is not good, the access for do that procedure, if it's EST or if it's full thickness resection or if it's even EMR, you don't have access. What happens if complication occurs? Do I have enough access? Do I have a good view, etc., to handle it? If not, don't start. So those are those elements I think about before I start.
So I fully agree with you, and I think it's very important that for everybody who's listening, that there are certain things that are the fundamentals that we should always be thinking about when we are dealing with these things. So I'm going to share with you here on the screen. So the thing that you're talking about, you see my screen here, right?
Mm.
Yeah, so
Exactly.
we're talking about the 2024 colorectal polypectomy guidelines published in Endoscopy. I think pretty much this is a very good framework to. I mean, you do not need to memorize everything here. But if you just print this out on an A3, like a large piece of paper, and just have it like on the board in your endoscopy room, I think with this would save you a lot of headache and decision making. So as you said, like about 90% of polyps are like a small diminutive polyps that can really be removed easily with the cold snare, as you can see here. And you can see my pointer, right?
Yes.
It'll do like nine. You can still do this cold snare polypectomy. Only when it's like above 10 mm, that's when you need to start looking closer, of course, and then you're gonna need to decide. And you said already, like SSLs that are large, no dysplasia, you can easily remove them with cold snare. But with adenomas, you have like lesions that are pedunculated, probably you should opt for hot snare. So I think this is a very nice framework. We do not need to go through all of it. I think we're going to be touching on a lot of these different scenarios in today's talk and in the next episode. But pretty much a lot of what we're going to be talking about is going to revolve around what is on this image. Do you agree with me on this?
Absolutely, absolutely. And again, I want to just this is a very good. You can look at it, and this is a good framework. Pay attention to that point. I think I like it. Advanced endoscopic imaging. Once you see the lesion is bigger than 1 centimeter, you can always remove everything, whatever you want. But stop, think. Should I do that? Am I sure what kind of lesion I have? I have seen colleague be too fast, started to remove a cancer, and then you are in trouble. So look at, even you can find cancer, of course, in the lesion less than 10 millimeter, but it's much rare. But if the lesion is bigger than 1 centimeter, please make your optical diagnosis first.
I agree with you. So yeah, we may come back to this flow chart a couple of times during today's
Yes.
talk, just to follow up on where we are. So I'm gonna stop sharing here. And yeah, so this is great, Morteza. So let's say like right now, as you said, 90% of these small polyps can be removed by cold snare, even some of the larger ones. Um, and I mean, colds shifting to cold snare from hot snare is, I mean, in terms of time-wise, it's a relatively new thing. It has not been around for like decades. Um, and this shift, like, it's changed practice, made things faster, made things safer in many ways, but it still scares a lot of people because it can get bloody when you remove things cold. When you remove things hot, it becomes dry, but it gives you this false sense of security, right? Like, oh, it's dry now, then it'll be fine. So the patient shows up a few days later with a delayed perforation or delayed bleeding. So, uh, what do you think are the key reasons for the shift from hot to cold snares, and where do you still see it being done badly nowadays?
I think at the same time that we get more and more dedicated snares, which is our today our very usual of using for cold snare, and also the knowledge and the lots of study comparing what happened if you take it more superficially, which you do with the cold snare compared to hot snare, show that there is no difference regarding to recurrence or develop into cancer, etc. Uh, and some studies shows in the benefit of cold snare anyway. But I think the most most reason for changing for a hot snare, even for small polyps, to a cold snare, is the rate of bleeding and complication. Delay bleeding is almost zero. It's very, very, very rare. That you mentioned that you get a false impression that, oh, everything is right, nice. I retrieved this endoscope, but you have to know that you have coagulate small vessels, and that coagulated might relieve later on and start bleeding. Once compared to cold snare polypectomy, everything is bleeding now. And if you see that the bleeding is stopped, then it's not going to bleed again. Most of the cases. So I think that is, and also very fast. You don't need to delay the time to use the hot snare with all devices you have to put on the patient, etc., and also the cost. So when you see one method is as good as the previous method, it's much faster, it's easier, and it's cheaper. And we don't forget about the environmental effect as well. So cold snare is gold standard for small polyps, right?
Yeah. I think the situations where it's not being used optimally is most probably, I would say, I mean, other than that technique, which can be with everything in endoscopy, right? I mean, it doesn't have to be polypectomy. It can be just the regular insertion or withdrawal technique. I think the biggest issue with cold snares that may occur is the wrong choice of the polyp. I mean, you go and try to remove a polyp with cold snare that should not be done with cold snare. I think this is the major mistake.
Completely agree with you, and that's why the latest polypectomy guidelines that you showed a slide of has described what kind of lesion are suited for cold snare polypectomy, and what you should go for hot snare polypectomy, which I'm going to also touch in my slides. So that's of course you have to know what you are doing, what you are using, as no matter what kind of method you choose to use. So yeah.
Maybe just a quick thing, like just to be the devil's advocate here, something that may about being on the verge between cold and hot snare, and we're gonna be talking about this more in detail. One thing that I used to sometimes struggle with, or even until today, sometimes becomes like, should I do it this way or that way? Is like you have these adenomas that are close to 1 centimeter. It's really hard to tell if they are like 10 mm. Are they 9, 8 mm, or are they 11 mm? Sometimes it's difficult to tell, like, especially they're sitting on around a fold or something where you cannot really estimate perfect size. And where basically you may decide to go, for example, for cold snare, and then you realize that you had removed, let's say, 11 mm of tissue, or vice versa. My personal impression is that it doesn't really matter if you end up removing an 11 millimeter or adenoma with cold snare if you're sure about what you're looking at. Guidelines make it pretty much like, they make it very crystal clear on 9 is your cutoff, and after that you can go for hospital with an adenoma. But I mean, in real life, really, I think it's really hard to kind of tell between 9 and 10 mm, because even the 10 mm snare, yeah, okay, it's 10 mm, but like a 10 mm snare, when you put it around the 10 mm like a 10 mm polyp, it looks almost twice as big as the polyp itself, because the biological tissue, you can kind of work with it and basically just wiggle the snare around it so that you can grab much more tissue than you actually need. So what do you think about that? I mean, do you think If
I agree. I agree with you at least partially because it is difficult to always exactly say what's exactly the size of the lesion. Of course, if it's a sessile-serrated lesion, and again, optic diagnosis comes in my thought. Optic diagnosis. If it's a sessile-serrated lesion without dysplasia, then we have then I don't use hot polypectomy at all. But in terms of, you say, even it's adenoma with low grade dysplasia, the new guidelines, as you mentioned, says between 10 and to 19 you should use hot snare polypectomy.
yeah,
But you see, okay, it's maybe 10, but maybe it's 9. But when you take that one, oh, a little bit left. Did I do a very
yeah,
wrong thing, or can I
yeah,
continue with the? And it's, I think it's not wrong to take it in two pieces, but some kind of reservation here. Uh, I think the reason that if it's adenoma, try for going for hot snare polypectomy, it's the fact that you may miss some part of lesion that is not only low grade dysplasia. Maybe you have a high grade dysplasia. Then you ensure yourself that you took it in one piece with the 15 or 20 millimeters snare, and when the histology comes back, I say, oh, I thought it was low grade dysplasia, but it's high grade dysplasia. No problem. It's radically
yeah,
taken. But if it's in
yeah,
two pieces, then you
yeah,
oh, okay, did I do it? That, I think that's the only reason. But if you are very very comfortable with your optic diagnostic and you can see it's a right colon, low grade dysplasia, all those classification that we mentioned, some of the JNet 2A, regular glands, regular capillary. Before we did that, before this recommendation, we took 15 millimeter tubular adenoma with low grade dysplasia, maybe in two pieces, and then it was not, and the studies that didn't show that those kind of lesion goes to cancer much more. But I
yeah.
think that there is that's the only reason that you go for hot snare polypectomy, not missing eventually high grade or even worse a very early cancer.
Mm,
So
mm.
recommendation is if it's a tubular adenoma, is a dysplasia bigger than 10 millimeters, cold snare polypectomy is not suited. But we're gonna touch that as well.
Very good. Yeah. So, yeah, this is like such a big topic. We
Yeah,
were
yeah,
talking about it.
and also the other thing that was it was also issue. A colleague asked me, okay, I took 13 millimeter lesion. I'm sure I took it radically, but histology says it's not radical. And even in 9 millimeter, you put the cold snare on it. You suck the lesion, the specimen into the to capture the lesion,
Yeah,
but it maybe you
yeah,
damage it by suction that. So it doesn't matter. So what is radically, is it histologically or it is
yeah.
optically? So I think today it's much better that description that, or if you see that you have taken it radically and you can document it, so you don't need only go after histology, of course, unless it's much more grade of dysplasia in it.
On the cold snare. So, can you walk me through the technical details that actually matter most for complete resection? Like,
Yeah.
such as, like, spoke of the margin, about like the capture positioning, which snares to choose,
Mm.
how the lesion is engaged,
Yeah.
and what makes a good snare for
Yeah.
different jobs. And maybe as we go through this, if you can show us an example
Yes.
of
I have
what a
a
proper
yeah.
a proper polypectomy pulse snare would look like.
I have collected a couple of slides. So if you think that I should more focus on anything, just let me know if you want to comment anything, or if you wanted me to to go to next one, just let me know. So let me see if I can share it with you.
I think you can definitely tell us about that, and then we try to speak about it even more as we show the videos as well, so that it becomes more and more
Absolutely. Do you see
interesting
my
for
slide?
people. See it, yes, perfectly.
Good. This is a general tips about polypectomy generally, in both cold snare and hot snare. I know, I'm sure that you know about it, everyone knows about it, but I think it's good to think about it before you start it. I have a strategy, and the strategy is coming more and more important. The bigger lesion is, and the more advanced resection type is, of course. And the position of the patient, especially when if the lesion is bigger, or you may get a bleeding, etc. So what position the patient is on, what happens if it starts bleeding, etc. Straight instrument, that's of course very important. You have to be able to have what we call it one touch. Everything you do with your wheels or whatever, you have to see it and implant it in the front of you, in your view. And for us in the Western countries, the working channel for colonoscope is 5 to 6 o'clock. I think it's the same in your country, right? And endoscopy 190 series, etc. It's it's in Japan, and in Britain it's a little bit different. Do you hear me, Summer?
And it's the same here. Yes.
Okay,
it's the same.
good. So try to have the lesion in front of your working channel, and don't work with the distance. You work very close to the lesion. And when you ask the nurse, close the snare, just make some compensation, advance with your snare toward, because otherwise everything is coming back to the working channel. So for cold snare polypectomy, that is what you can find in the recommendation from ESG guidelines. All what we call diminutive polyps, if it's SSL or it's adenoma, you can remove it with the cold snare polypectomy. The lesion less than 5 millimeters. All the lesion less than 10 millimeters, you can also do the same thing with. So basically, all lesion less than 10 millimeters, it's cold snare polypectomy. Then if the lesion is bigger, as we mentioned a couple of times, it's a cell without any dysplasia. So cold snare polypectomy, no matter size. If it's bigger than 25 millimeters, we call it piecemeal cold snare polypectomy. That's a new definition. But since you see your SSL has dysplasia, so cold snare polypectomy is not suitable, right? At least if it's a little bit bigger, you have to have you cannot take it in the pieces. And also you can combine cold snare polypectomy, piecemeal cold snare polypectomy with the lift. The reason for lift is you see the entire lesion much better. You don't miss the border of the lesion. It's easier to catch. It's much easier to do cold snare polypectomy when you lift it. And if you have the last point, if that's also recommended, we talked about if it's dysplasia, we don't do it with the low grade with the cold snare polypectomy. But if the patient with comorbidity in the right colon, then it's completely okay.
Okay.
And also you have if you have experience enough. So your snare has to be dedicated, and the twisted metal wire of snare should not be thick. Some of them is 0.32, some is 0.36, but something around that. And because with snare with polypectomy, actually, you remove the lesion by two things: by cutting and by giving, the electricity. You exploring the cells and then make the cutting and coagulation at the same time. Explain very simple. By cold snare polypectomy, you use only the cutting function of the snare.
Yeah.
And also how you can cut with the snare, because if you put your finger of the snare, you don't cut your finger, right? It's not that sharp. But when they close the snare, it's going back to the plastic sheet about almost 2 centimeters. Have you noticed that? When you completely close the snare,
because it always goes in beyond, like,
it goes
yes,
in
of
about
course.
2 centimeters, and that dynamic mechanical things make that the lesion cuts, because the lesion cannot go to the plastic sheet, but the snare does, and that make a cut. That's how you cut the lesion with the snare.
Yeah. And I guess this is also one of the reasons why you should not work so far from the tip of your endoscope, right? Because then if you work so far from the tip of the
Exactly.
endoscope, as you're pulling, as you're closing your snare on a polyp, what you end up doing, you end up pulling and tethering, like, maybe the submucosa and maybe some of the muscle with that
Exactly.
distance and with the movements of the colon into the shaft, and, like, everything, that all the risks that are coupled and go along hand in hand with that. This is why, as you said, like, just work as close to the
Yeah.
tip of your scope and stabilize.
Exactly. I mean, the sheet shouldn't be so much far away from the tip of an endoscope. Actually, I don't want to see the plastic sheet when I put my snare around it. Once
I do the same thing.
once the nurse close it, then I push it toward to the lesion, just to make a compensation. So that's correctly the reason that you said. So when you put the snare around it, so include a couple of millimeters of healthy tissue to make sure that your resection is radically, of course. And the problem is, you go tangentially parallel to the mucosa with the snare, and if you just close it, you may just slide over the lesion and don't take enough, and your resection is not complete. So once your nerve's gonna close it, make sure that your tip is toward to the mucosa and the muscle. Just fix it, as a very simple word. You fix the tip of the lesion that you can catch the mucosa. You know what? Do you understand what I mean?
I understand what you mean.
Yes.
Can you explain this again for people who are listening?
Yeah,
This might be a bit
you
confusing.
you can see it. You can see it in this picture. Can you see my pointer?
Yeah.
Yes. That's when the nurse is. I told her close the snare. You see the lesion here. I put a couple of millimeters around, and I just try to push it forward, not because snare is coming toward to me. I missed that part, so I just fix it with the tip of my snare toward to the muscle, perpendicularly to the muscle and to the mucosa, until I see that everything goes inside the lesion, including a couple of millimeters of healthy tissue.
Yeah. Okay. And in terms of the shape, the stiffness, and the size of the snare in daily practice, do you have any preferences or any recommendations? Let's say, maybe, like, we should not focus on, like, just the brands. I know we all have our
No.
what's locally available and what we like to use. But in terms of, like, the fundamentals, what would you prefer? How big would you prefer them to be? And what shape do you like, and so on?
I think basically three things is important for me. Once in the as I mentioned, the size of twisted metal snare. It shouldn't
Yeah.
be bigger than 0.3. The second the second thing is I don't
The
use
thickness, you mean the wire thickness? You're
the
talking about
wire
wire thickness.
thickness.
Yes,
Yes,
yes, yes,
the wire
yes.
thickness, not the size of the snare when you open it.
Yeah,
The wire thickness.
yeah, right.
The second is the size of the snare. I mean, we mentioned that you use it for lesion less than 10 millimeters. So
Yeah,
I don't use cold snare bigger than 10 millimeters. There is no need for that. Why should they? I know at some company they have 15 millimeters. When do you use that? I don't think you need it. The risk is that maybe you take some part of muscle with you, but with 10 millimeters, you normally you don't take muscle layer with you. Do you agree?
exactly. I agree fully. I agree fully, and
Yeah.
I refuse. I refuse to use any cold snares that are bigger than 10, because I mean, if you're gonna do something bigger than 10 with cold, then you might as well just do it
Yeah.
with piecemeal,
Eh,
because I mean, you will not be able to cut something bigger than 10
Yeah, and I
in one
think
go.
I talked to the some company and I asked them why do you have 15 millimeters? Because normally those 15 millimeters and even some company have 10 millimeters snare that you can use both for cold and hot snare.
Yeah, the
Uh,
hybrid ones.
the
Yeah,
hybrid one. I think that metal thickness is a little bit thicker, and also that's why they have also 50 millimeters. If you have a bigger lesion, you want to take it with the hot. But my recommendation is 10 millimeters is completely enough, not bigger than that. The third thing is the some cold snap some cold snap type I have used. Once you this step, once you push it toward to the lesion and you want to close it, so the tip of the snare is not shaped that stay without moving, and this part this forward part of the snare is tipping up. Then I miss the lesion. You know what I mean?
yes, yes.
Yeah. So
Mm.
there are a couple of that I have actually used those snare, especially when you are doing in a fold in the right colon, etc. So once you're going to close it, you see the tip of the snare is just tipping upward and unnecessary. You cannot do a good polypectomy. So basically, those three is important for me, no matter what brand it is.
And I fully agree with you. I mean, I've used a couple of the hybrid snares, like, I mean, examples, like, for example, the Snare Master from Olympus. And usually the wire is about 0.47.
Yes.
So, and it's usually a braided wire. So yeah, you can cut small polyps with it. The
Yes.
problem is that quite often what you end up getting is like you grab you grab your polyp, and as you close, you see that basically you're strangulating the polyp, but it's not coming off.
No,
Which
exactly.
sometimes all you need to do is wait until like the wire the cheeses through or cuts through the polyp itself.
Mm.
But sometimes, like, some that I don't recommend, some like where you basically you do the cold avulsion, where like you just pull at it.
Yeah.
But
I don't. I don't.
I don't like that, because that thing done, like, and violently, may actually give you a big problem. And also the other issue that may end up happening, is that you may get like this quite significant submucosal punched out mucosa. I think you have something that is like that third picture you have down there that you're sharing. Like you have that punched out submucosa that is just like looking right at you, and we know it's nothing, like, we know it's not. It's been studied, I think, by the Japanese, where they sometimes they say, oh well, maybe there will be some residual polyp in there, but the consensus is that you don't need to care about it. It's just punched out submucosa, and usually it's very hard to take. You can't, even if you put a snare around that part, it's not easy to cut.
Yeah. I agree, and I don't like those snare either, because as you mentioned, if there are small lesion, diminutive lesion, they cut it. But if it's a little bit bigger tissue, you struggle with the cutting that. And once you said, I don't pull it either because it cause damage. What I do is ask the nurse open it, not fully, but a little bit. I go more close to the lesion, but I pull back the sheet of the snare back more back in the working channel, and then ask them for close it. But the problem, whatever you do with you have that's struggling, is you see your specimen many times it's not in one piece. You cut the lesion in several pieces, and we don't like it when you see it in several pieces. Once you could get it with one piece, if you had a better snare in your hand.
It's a small polyp where, then all of a sudden, per definition, you ended up doing piecemeal EMR, and and then patient needs to come back after 6 months, and and then everything else. So it's like really something that you need to think about if you're gonna do this. So I'm gonna show you so while we're at this or maybe you can show us before that a video of how a proper cold snare polypectomy should be done, because then I have a video of what can happen if you are actually using the wrong snare and you start tugging at polyps, and how you can actually end up causing a perforation because of that, as unlikely as it may seem to be, So please tell us how the master would do it first.
As you see here, it's a very let me just see here. It's a diminutive tubular adenoma, and you see here, I make sure that I have enough of healthy tissue around it. Once you're gonna close it, I just push the sheet forward, and then just water inside it. Pump the water and look at the resection area. This is a small lesion. It's between 5 to 10 millimeters, tubular adenoma with low-grade dysplasia, as you see. And again, make sure that you cover the whole lesion. And look at here. Once she's gonna close, I go forward. That I make sure that the distal part, the part to me, I catch the healthy tissue as well. This is a SSL. And you can see it more clear when I put the ethnic acid on it. It's less than 2 centimeters, so it's a cold snare polypectomy, a couple of pieces. You see, I have enough healthy tissue at the right side. Make sure that I got it. I retract the snare, suck the first part, and then cover the other side. I overlap. And you see that at the left side, I ensure that I have the healthy tissue, and then I cut. Then after that, of course, you look at the whole area, then make sure that you have done a complete resection. You want to show us something now?
Yeah, and after, just before you do that, after you right after you did that, you will wash the area, right?
Yes.
Properly.
Yes. Yeah.
You're gonna inspect your defect, your defect. Make sure that there's nothing left.
Exactly.
And take that image, because there's a lot of people that take that image right as they take the polyp. They cut the polyp, and it's still it's cold snare, so there's a bit of blood there, and you take a picture right there and then. But then you cannot tell anything, right? So you need to have your foot on the water jet clean so that you actually see your resection defect, right?
Yeah, and also the other effect that you can get with the pumping water to the resection area is, if you don't like that even small oozing bleeding, you see that. So push the water, and the water goes to submucosa and make some compression of the small vessels, and stop bleeding is faster.
So that is also one thing that is definitely, and this is where a cap also comes in handy. And,
yes.
and all of that. So like this is a really
So
good
can
way of
yeah,
yeah.
when do you use a question that I get? When do you use any kind of hemostase after you do cold snare polypectomy?
Called Snare Polypectomy, like as in a clip or something. Is that what
Yeah,
you're
yeah,
talking
yeah,
about?
yeah, yeah, yeah.
I never do it. I don't
Okay.
know if you do.
I think when you look at some recommendation, if you stay there, you wash it, don't be hurry. Wash it, take a kind of documentation, let it go, and if you see it stop, which is most of the cases, it stop. So then you can continue. But if you see it's still oozing, especially in a patient with and with anticoagulantia, so 30 seconds, it's kind of good cutoff. If you see that it's still oozing after 30 seconds, so as you mentioned, I put my distal cap on it, make a pressure on it, and then
Uh,
it's always enough.
but I will challenge you here a little bit, where like some people say, I mean, if I'm gonna remove 10 small adenomas or SSLs in a patient, am I gonna have to sit there for 30 seconds in front of each polyp to see if it stops bleeding? If the patient doesn't have, if the patient, like, even if the patient is on antiplatelets or anticoagulants, but they've stopped their drugs in time, like, according to the latest guidelines, and, you see a little bit of the drops of blood that is still coming. I mean, uh, do we really need to sit there and wait, or can we just blissfully ignore it?
No, 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 no,
And
no.
and,
If
and
if you see that most of the cases, after a couple of seconds, you see the bleeding stops, then you don't need to stay 30 seconds. I just say those
yeah.
cases that you still that is still oozing, is still oozing, is still oozing, then you can use 30 seconds method for. But if it stops before that, you just leave it.
I mean, I understand it. I would definitely be, uh, and of course, like this is something that is like no guideline can really individualize for all the
Yeah.
different scenarios that we deal with in real life. I mean, let's say you're doing an endoscopy on a patient that had PCI recently, and they're on dual antiplatelets, and you want to resume them as soon as possible, and you don't want this patient to, like, bleed after the procedure, then maybe you should be more, let's say, generous uh, with your hemostatic, like, approach, compared to a patient who's, like, totally healthy, not on anything, where you may, like, kind of be more, let's say, tolerant to a little bit more blood. So I think this is also one of the things that where common sense actually really comes a long way, and this is one of the things that I think no guideline can really address
No, no. I mean,
fully. So
that's one thing. The other thing you can do, if you have to do the colonoscopy with under some kind of patient that you mentioned after PCI, etc. So, and you see the small, tiny diminutive lesions, if
yeah,
it's okay for the patient, then you can reschedule the patient after 4, 5, 6 months when the
yeah.
anticoagulantia is reduced or just out. Then you can do your colonoscopy. So it's you have exactly as you said, you have to individualize the case. What kind of patient you have? What should I do?
Like, this is a very interesting, like, I really like, so you showed us how it should be done, right, the
Yeah.
right way. I'm sure, like, one way, this is one of these cases where I was training one of our fellows, and I was out of the room, and, like, there was, I'm a big proponent of full snare, so I would talk about it.
So I
And
stop. I stop sharing, right?
you don't have to. I will
Okay.
just take over
Good.
from
Good.
here.
Good.
So you see my screen, right?
Yes.
Yeah. And so what happened here was, this is a hepatic flexure, small polyp. I think it was, I don't even remember if it was an SSL or an adenoma, but um, uh, the colleague removed the polyp, but like, I think it was not the right snare. I think it was a hot snare, 10 hot snare was used to remove a polyp cold. And you got this thing where like basically the coarctation, you're grabbing like the polyp, it's not cutting, and then there was some tugging, and the tugging was being done multiple times around the hepatic flexure. And then I was called in the room when like the polyp was off. And when I came in, like, I started recording what was happening. And this is what you see right there.
Mm.
Yeah. And this is right to the hepatic flexure. And you see the amount of like, the edema that you're getting. I mean, it looks, it looks much worse than. But you see the edema that happened because of continuous tugging at the polyp, that was definitely less than 1 centimeter. You see
Yeah, yeah,
the
yeah, yeah, yeah,
size of the area.
yeah, yeah,
So
yeah.
yeah, so this patient back then, right away we used some contrast because I was not very happy with what this looked like. And we used some contrast here, like with fluoroscopy. And when we injected some contrast, or like we sprayed some contrast over, I could see that some contrast was leaking outside. So because of this, there was some mini perforation under this area because of the shear force that was used with a cold snare. So like as safe as cold snare is, and as great as it is, you should always be careful and you should have the right technique. So this was a mini perforation that was at the hepatic flexure that should not happen really if you're using the right type of snare. And you see like how difficult the angle is. It's not really that easy to get around it, and because of the edema and everything, it's really and this is like this video was taken after doing the like doing washing and waiting for the blood, because when I came in the room it was rushing the blood from that area, and we had done already the fluoroscopy and everything. And then I ended up like having to clip this area shut because of this, and like having to use so many clips. Like the procedure was prolonged by maybe like 45 minutes because of the difficulties of getting around it. So what I'm trying to say here is, there's no need for heroisms. I mean, try to understand the type of lesion you're dealing with and try to remove it the appropriate way to avoid ending up in these situations where you will have to do something that, like, you will have to fix a problem that should not happen in the first place. And it's not always an easy problem. I mean, this patient that has not been closed, maybe this patient would have come back that day with peritonitis, and maybe it's not like a covered perforation, maybe it's a frank perforation, and maybe the patient will end up getting a right-sided hemicolectomy, right? And these are
Yeah.
things that I think are very important to think about, and when we're dealing with cases like this. So so as you said, like, you asked me, when would you clip, you do hemostasis on on a cold snare? This is one of these very, very few cases where I would have done it. Uh, but of course, I agree with you. Like, I mean, if you see something that is not looking great, and you see that, like, okay, this is giving me a headache, maybe you're better off, just putting
Yeah, I mean,
a clip and call it a day.
that was a very, very, very good case to show. I think what happened there, it's not only the cold snare polypectomy, because the reason that you say that lift up the polyp when you do hot snare polypectomy, it's to make sure a distance to the muscle layer, right? I think I
Mhm.
like your idea that to make sure there is no perforation has had occurred, because by just try to with that actually wrong snare to strangle with the and make that ischemia. That exactly the same thing that you do hot snare polypectomy without lifting. You give coagulation and ischemia to the muscle layer, even though you don't see the perforation at the time. Maybe patient get the delay perforation because you have caused ischemia, and you have bicoal snare polypectomy method here. Maybe you have done the same thing. That be aware that eventually that muscle area, it's not the thing. The difference here is only this: you have a bleeding also, which you don't have with the hot snare polypectomy. So here is a bleeding issue, and also how much ischemia have the muscle got by that technique was using. So think about that perforation as well. This is it. This is exactly what we're talking about. Dedicated snare. Think what you are doing. If something is wrong, if I don't catch it, if I cannot cut it, so I just open the snare, I'll leave it. It's better than harm the patient with the other things. So well done, very nice demonstrated.
So let's say now we have like one of these lesions that is like bigger than 10 millimeters, but like, say, as you said, it's an SSL without dysplasia, where guidelines are pretty clear on this, where we can remove them without using diathermy in pieces, in piecemeal, a cold piecemeal EMR.
Yeah.
Can you please tell us a little bit about
Yeah.
that, and what do you
Yeah.
think?
Yeah, I mean, I show you the video clips at the same time. This is a lesion uh, in a sickle in a sickle, and after I make sure that it's only a SSL without any dysplasia, and this was a big one. It was more than 20 millimeters. So recommendation is lift it up, and I have only saline with the indigo, and the principle is the same thing. Make sure that you have healthy tissue, and here you have to have strategy. My strategy in this case was my access everything. When I check it at the left side from the above part, so just go down and take pieces with the margin of healthy tissue, and then I go up again and do the same thing at the right side until I get here. You see there, and then I go up here and then working downward to make sure that I don't leave any small island of lesion. And you see here, that's one part of the upper part there that I missed, but I know about it. I have to check all my borders very, very carefully, and you see it's bleeding, but it's bleeding stops pretty quick. You see,
Yeah, yeah,
take margin. Don't be aware that your resection area is getting bigger. It doesn't matter if it's 25 millimeters or 30 millimeters. It's not a big deal because it's very, very
yeah.
superficially resection you are doing. And the
Hmm.
worst thing is to leave uh, lesion, not do complete. Narrowbanding is good, but I like RDI, as you're going to see here. If you have the new X1 process, you see the effect of bleeding is less clear. Then you can see the resection area much clearer, and you can just go through the resection area piece by piece. And if not sure
Hmm.
if it's normal tissue or it's a little bit residual or a little bit lesion left, just cut it again. So basically
Yeah.
it's the same technique, but you have to have put some strategy and lift it up when it's big, when it's getting bigger, at least bigger than 20 millimeters. It's much easier. You cut better, and you see the whole lesion much better also.
So this is great, but I saw exactly what you did there. You had like the perfect kind of position to remove this polyp. But I think something that we can always recommend, or like, maybe suggest for people to think about, is that if you're gonna be dealing with piecemeal, whether it's cold or hot EMR, I mean, maybe the best thing is to start with the part of the polyp that is where you have the easiest access, because then once you remove that part, you can use that defect to anchor your snare to grab the next part. Would you agree with this assessment?
Yeah, in some cases, absolutely. Normally, when we are doing uh, polypectomy, definitely when we are talking about advanced polypectomy, we always recommend that start with the most difficult part, because difficult part, that's getting easier. But I agree with you. In some cases, when I know I have to have some place that I can overlap or anchor to make that part that I cannot catch it now. But I go to the easier part to make sure that here I create an anchor for me. Then I can go to the more difficult part. But normally it's start with the difficult part, or regarding to your access to your strategy, start with that. Have your strategy clear. Don't start and then think about the strategy. In this case that you saw, the lesion was in the bottom of cecum. So for me, what if the right side position of patient was obvious for me, because everything I wash, it doesn't stay there. All the liquid coming to back to ascending colon, and I can have a very clear view. That was the first thing. I put the patient on the right side position, and then check my access. Do I need anything else to have the best access? And then during the access, what do you say? Before I cut, I just go through my procedure without cutting, up down up down. Okay, then I see it's doable. Then I go for it. I kind of memorize it, or what do you call it? Yeah, you know what I mean. I
Yeah,
I
I mean, it's
I
yeah,
pretend that I'm
pre-plan. Like, I mean, the strategy is clear from the beginning, and I think
yes,
very
yeah,
important to uh, vocalize this strategy to your assistant of what you're planning to do
exactly,
here, right? I mean,
exactly,
like, we're going to be removing this, and this is how we're gonna about doing it. Do you sometimes feel that you need to re-inject when you're to get lift again when you're doing cold snare?
yeah. This
Yeah,
size, this size maybe not. And I'm if it's very, it's much bigger, of course.
yeah,
Then I don't lift the whole entire lesion, because maybe it's getting make it trouble for you and make it difficult. If I decide, okay, these 2 centimeters or 25 millimeters, I'm going to go for it, and the lesion is 4 centimeters, 45 millimeters, then I start with that part. I'm gonna remove first, then I re-inject the second part. But for this size, it's you don't. I just lift it once, and it's there. So
yeah,
so so you choose your strategy and check your strategy. That's
yeah,
what I mean. Check. Okay, I want to start up to down. Is it doable? So I do without cutting. Just go down and to the other side. Okay,
yeah.
then you do the same thing again by doing procedure as well.
Yeah, I think that is a very good way, because I mean, this is pretty much the same way that you're gonna be doing a hot EMR or
Yes.
piecemeal EMR, where you need to have like this kind of, you need to have good access to the polyp. You need to be able to get around it. You need to have a straight scope, and you need to work systematically. You
Yeah.
know, um,
And
when you
leave that resection. We don't be afraid that leave that resection area.
yeah,
We're gonna talk about hot snare polypectomy and the piecemeal EMR, hot piecemeal EMR, etc. Then it's other captured when you're talking about closure or not. But here I do not close the after piecemeal cold snare polypectomy. Normally, I don't do that.
So as you said, we're gonna be talking about later on about the standard piecemeal EMR, which is the hot one later on, where treating the edges of the resection defect is a part of the job, which is this STSC or snare
Yes.
tip soft coagulation. And so when it comes using a hot snare, it, it's a very clear guideline and there's a consensus about it. Although I mean, the level of evidence I think is moderate at best there.
Yeah.
But when you do a cold snare piecemeal EMR, would you sometimes think about maybe you should use a little bit of diathermy to burn around the edges? Because the jury is still out there on this. There's a randomized control trial ongoing, but I haven't seen any results
Yeah,
saying
no,
whether
exactly. There is no data yet, but instead of using that, so it's much easier to take a bigger piece of the healthy lesion with your cold snare polypectomy, as you see here in the last part. I thought maybe I left just less than 1 millimeter there, but I take 6-7 millimeters of the healthy issue as well. It's much faster than you just gonna change it to the hot, put
yeah,
the thermi on, etc. But we do need the data to show it. But
yeah, yeah,
until today, I don't do that. I make sure that I have a clear resection area, clear border edges. Watch it, and I always watch it with RDI.
yeah. I mean, I quite often I do the same, and I use near focus as well to just come
Yes,
as close as
and
possible.
if I hesitate, hesitate if it's maybe there or not, just take another bit.
Yeah, take another bite at it. Yeah,
Yes.
it's very. We're gonna be talking about this. Like, I mean, it's very. I mean, we can really, first, simply speaking, you can do the same when you're doing a hot snare EMR. Or why not just bite a bit more? Why are we spending so much time burning around the edges? But that is a I think
I
a
mean,
topic that we can talk about.
yeah. We have to also keep onto the recommendation as well. There is no recommendation by today to do STSC on the cold piecemeal EMR.
Recommendation to it. I've seen some people. I've seen people do it.
Yeah.
And advocate for it. But I mean that's just like case studies. There's not much robust data there. But there is a trial ongoing. I think it's also in Australia about this. So we'll definitely find out in the future what the practice what practice is going to be like in a couple of years from now. It's a fast evolving field what we're working in nowadays. I guess it's
But I think if you're gonna be fair, so you have to compare more cutting a piecemeal, because if you look at that lesion I had, maybe 10 more bites around the whole lesion I could take in few minutes. It takes less time than I'm gonna change it and do STSC. But but if you leave it and then compare with the STC, of course STC is gonna show you the favor, because exactly the same like a piecemeal EMR. But we'll see what data shows.
it would be a more expensive thing because then you're opening
Exactly.
one more, like you're gonna there's a lot of things that you need to think about when it comes to
Yes.
that. And I think we need to keep in mind the environmental impact of everything we're doing and and also the economic impact of everything we're doing. I mean,
Absolutely.
there are different ways, I think. I mean, there's never one way to do everything. And I think this is very important for people who are just listening. I mean, we're talking about a lot of things, many of which are like, kind of anchored in guidelines and recommendations, but we are also um, kind of deriving many of the things that we're saying from our own experience, right? And what we're used to
Yeah,
doing and what we have seen work and what does not work, and from speaking to people who know a lot about this. So, but that does not mean that this is the only way of doing things. There are many ways, but there's also the wrong way of doing things, and this is what we're trying to steer away from when we're doing this. Is how to optimize the outcome for your patient. Because the worst thing is like you have a patient that comes in and let's say you remove 10 polyps and you're so happy about it, but then the patient shows up 2 years later with a post colonoscopy colorectal cancer just because you did not pay attention to some fundamental issue during your index colonoscopy, right?
yeah, exactly, exactly.
Okay, Morteza, I think this has been great as always.
Thank you. It
I
was
really,
very great with you.
I always enjoy speaking to you. I always learn a lot from you, and I think anybody who's listening to this would learn a thing or two from you as well. And
Thank you.
next time, we will be speaking about the other type of polypectomy, which is hot snare polypectomy, and a piece mainly EMR, and then we'll follow that with one final episode about underwater EMR, full thickness resection, and ESDs. So that way, I think we'd cover like the whole spectrum of polypectomy from mucosal to submucosal work. So thank you so much for being with us, and I really look forward to seeing you again soon.
Thank you again, Summer, for a great job, and thank you for having me again. Thank you. Bye bye.